everybody. Welcome to our Saturday morning tea, where we discuss health information, news, education, and certification tips. And then we also have all kinds of other tea that we that we throw in. It's a great time had by all, I think.
I agree.
I'm Clarice Warner, the girl with the pearls, the founder and education director of the Professional Reimbursement Network, LLC, where coding education is key. And before I introduce my co-host, today's episode is sponsored by PRN's free email course on the 5 steps to become a certified marketable medical coder.
Are you interested in medical coding, but not sure where to start? And scared of wasting time and resources? Let me help you with the right steps to become a certified marketable medical coder. Learn more at bit.ly/5stepscoder.
In Clubhouse, feel free to click the link. YouTube and Facebook folks, you can check the video description for the link. So joining me today is my co-host, Mr. Jesse, the coding nurse. So, sir, introduce yourself and tell the folks all about you.
Good morning, everybody. Thank you, Clarice. My name is Jesse. I am the founder and CEO of the Coding Nurse, and the Coding Nurse LLC was founded in 2020 during the pandemic. And it was just a way for me to show nurses and people who work in healthcare, especially direct care, who were starting to experience burnout, how they could transition away from the bedside and find a remote and also financially rewarding opportunity in the broad industry of health information management. And I help them learn the ICD-10 and various code sets along with the reimbursement methodology to allow them to sit for coding credentials.
Well, look at you with that whole...
I'm getting better.
With that whole intro. I like it. I love it. It's professional. I love it. I want to shout out our Clubhouse folks today. Let's see. We have Dr. Terry, Tamisha, Daryl. Oh, I don't want to butcher your name. Tagwa? I hope it was correct. Kyla, Michelle, and Denise, welcome everybody. And feel free to come up to the stage. We will definitely have a Q&A at the end. Just make sure when you come to the stage that you keep your mics muted so we don't have any additional feedback. I have enough going on right now. Okay, so let's get into our topics this week. This one article that I ran into was really timely because I actually happened to be in a meeting and we were talking about, I guess, a slight crisis. It's sort of a crisis of low numbers of students that are actually joining the HIM profession, particularly in enrolling in schools. So the enrollment numbers have decreased in several states. And so there have been several meetings and discussions with educators on the whys and the hows and the whats. And then I see this. And so someone had mentioned about promoting HIM as a STEM career. And I thought, wow, that's a different strategy there. And there was an article that came out by Betty Wackendorf. I always try to give folks credit where credit is due. She wrote this article that talked about having HIM as a STEM career. And I thought, well, you know what? I do see the similarities. I do see where that could be a possibility. And so if you don't know what STEM is, STEM means sciences, technology, engineering, and math-related fields. The thing about STEM and why this is so attractive to the HI profession is that these STEM jobs are in high demand. but they don't necessarily have qualified candidates to perform these jobs. And so they're highly technical, which if you think about HIM, a lot of our services, skill sets, they're highly technical. Like I said, I see the correlation there. I was pleasantly pleased. They're also globally competitive. And, according to the article, STEM careers are important and necessary. Oh, don't forget, I'll post the article in the description box. So there was also a paper that AHIMA published in their AHIMA Perspectives called An Exploratory Study Demonstrating the Health Information Management Professional as a STEM discipline. So they've been looking at this for a while. I believe in the summer of 2019, some of the HIM educators got together and began the discussion about having health information management be included. And I think this would be a wonderful segue for getting high schoolers and younger folks. One, they need to know about the profession, but I think this helps kind of provide a conduit so they can see that it's highly technical, highly skilled, and has the opportunity for global growth. I think this article was really, really great to me because I could see where there are parallels. I can see what we do that kind of aligns. And it says things that, by comparison, what our competencies are. We have computer and information research scientists, database administrators, information security analysts, statisticians, computer occupations, etc. And so we are performing data analysis. We're doing that. That's the new kind of trend, if you will, for health information. We also have a couple of credentials that kind of lend to that as well, the CHPS and the CHDA. I just thought it was really a well thought out article, a timely article indeed, especially as they're seeing that people are not enrolling into the programs. And this gives folks something to look forward to. This gives folks something to feel good about. As a side note, we had another conversation and folks are talking about the value of their HIM credential. Is it really there? And so I think this is something that kind of adds value again to your credentials, to the organization, etc. So I think if this is something that they can push and move forward, I think this would be wonderful and great. I think the other thing, of course, that would need to happen is to, of course, provide information, provide education, particularly to the stakeholders like employers, human resources folk, teachers in high schools or high school programs, and those type of things. So I think this was great. Did you have any thoughts on this, Mr. Jesse?
Oh, I have a lot of thoughts.
Come through with a lot of thoughts. All right.
I think it's long overdue, and they are trying to have the same conversation within the nursing profession if nursing is considered STEM. And,
really?
Mm-hmm, and nursing and HIM are clearly STEM. I mean, it can't be any more STEM than being a doctor. I mean, you have to know anatomy, physiology, you have to know disease processes, you have to know medical terminology, you have to know, especially as a nurse, you have to know math. I mean, you have a lot of drugs you have to give out, a lot of drugs you have to calculate doses and drip rates and all that. So it is definitely a STEM field. The only thing that I'm a little concerned about is because, people love to lump everything together. So since nursing and since HIM are so overwhelmingly female dominated, would that throw off the STEM numbers as a whole? Because
I think there's always the concern that there aren't enough women in STEM. So
that's my point though. Mm-hmm. Like once you bring in like 8 million nurses and 5 million people, seriously, and you bring in 5 million people who women who hold HIM credentials, then there's look at how diverse STEM is, when it's really only 2 areas where that it's being dominated by women. And in the whole STEM, that does nothing for engineering, it does nothing for research.
So it's false inflation.
I think that it needs to be included, but I think that they need to make room for those wide variances.
Okay, that's a good point. That's a good point. I like it. Any other thoughts you had?
I think that, to be quite honest, I think this is I'm just speaking from a nursing standpoint. The nursing profession has been trying to validate itself as a profession for so long. And we know that nursing and HIM are led predominantly by white women. And this is the validation they've been seeking for years, because in healthcare, they ruined it with this whole like BSN situation. So if you're considered STEM, because what I'm trying to understand is, like, if you can go to like a 12-week coding boot camp and become STEM, why can't you become STEM if you graduate from a nursing program and actually have a nursing license? Like that to me is on the same level. So I think that this is the validation the profession has been trying to get. And I think this is a much better way to go about it than what they have been doing previously, because it's backfired the way they're trying to go about it.
I agree. I know that they, I guess in the article it discusses that they started this conversation in 2019, but I hope they really take the time to look at all angles and all perspectives. And to your point, make sure that they account for this potential overinflated number with the influx of HIM and nursing. I wasn't aware that nursing this was part of. Nurses try to get into everything, don't y'all? No.
Yes.
In my career, we've been fighting nurses forever, because nurses think they can do everything. Even though you guys, you do what you do, but leave room. Other folks can do things too.
That's true.
As you well know.
Nurses do have to work on sharing.
Yes.
I'll give you that.
Sometimes you guys come in with the takeover spirit.
Yes.
Like, Lord, give me strength. Let me. I don't want to sit this nurse down. Look, ma'am. And now, sir.
Listen, I appreciate it, because I go through that every Monday and Wednesday evening in my class, full of nurses, and they fight me on everything. Well, how come? Okay.
But I love that they will speak up. Now that I do, they will speak up and speak out about an issue, and curious, have a very high level of curiosity, which I think is something that, probably all professions need, but our profession, especially, I was having a conversation recently about, it was about leaders, and, folks are afraid to speak up to leadership. For whatever, they're kind of revered, like doctors, and I can't tell them that they're wrong. I can't tell them that they made an error. I can't tell them, it's like whatever they say, go. No. And I think there should be some sort of, I don't even know if it's training in that, but something from my perspective, one, I'm here to help in most capacities. And two, you put your pants on just like I do, one leg at a time. And so that makes you, yes, you have your years of education in your specialty area, but I got my years of education in my specialty area. And again, in the situation in which I'm referring to, so say I'm having a counseling session with a provider based on, maybe an audit or something that I've done, at that point, I'm not interested in your years. I'm interested in helping you do the right thing with your documentation and the end result of your reimbursement and your whole revenue cycle. So put them degrees and put all that stuff off the shelf. It's not. I'm not interested in that in this conversation right here. But some people get intimidated and overwhelmed, and it's like I couldn't tell them, and they'll come. Most of them have A personalities, and they'll come back. Oh Lord, they'll come. I'll never forget. I was having this conversation with a physician, and I had our COO there because I guess there had already been some instances with this particular physician where folks have come out crying and all kinds of craziness. And I was like, when I saw her, I was like, why are you here? She was like, oh, I'm just here to look over the office. And I was like, okay. So we go in and I start my spiel and I, tell her, because unfortunately her accuracy rate was well below what our standards were, well below even the Department of Justice standards, but that's a whole other conversation. And so I give her a spiel and I was like, one, trying to get to know where she was and what type of information she needed to be successful. So, you have some physicians who have no idea about anything related to documentation. They're just putting stuff down. They don't know the connections. They don't know. And so I'm really just trying to have a conversation with her to find out where she was. And, she was like, oh, I have never had a poor result on anything that I've ever done. And she went completely in. So I just sat back like, okay, let her have her 50 seconds of meltdown, because truly she had she started throwing papers and all kinds of, I said, well, look at here. So once she was finished, I was like, okay, are you done now? Because I'm here to do a job, and my job is to help you understand where we have some opportunities and how I can help you address those opportunities and create better outcomes. And at the end of I think I was there for actually an hour and a half, which I was only supposed to have been there for 30 minutes. But after an hour and a half, I was her best buddy. Literally, and from then on, she would call me, Clarice, I got a question about so-and-so and so before I put this documentation down, blah, blah, blah. And I was like, okay. So it was great. It went from one extreme to the other. But at some point, again, you just have to, I don't know, just, we're here to help. We're all in this together. It's teamwork. Teamwork makes the dream work. Come on, y'all.
I can tell you why that is. And I can tell you why nurses are beast at it, because in school you were trained to do that. They have a course that they have. I took in one of my classes, there's the role of a nurse, and a nurse takes on many different duties. Like you have a role as an advocate, you have a role as an educator. So you have to play different things at different times for your patients. And the advocacy piece, they take really seriously, and they really, really empower you, because ultimately, if you have to know, like, that's why, like, they are fanatical about pharmacology, because if you give the wrong medicine in the wrong amount, you can kill somebody. Exactly. And you can't, just because the doctor orders something, it doesn't mean that you have a right to challenge the doctors to not be nasty, but you do your own research. And I have corrected dosages. I know other nurses who have corrected dosages, know that that's over the allowed amount, or this person has an allergy the doctor didn't even check. It doesn't matter if it's even the right dose. If the person is allergic to a drug, they could have a fatal reaction to it. So those are the things that you have. So you have to be okay with not confrontation, but with being assertive. And what I found is, in this society, doctors have been placed on a pedestal, and really the only people who don't really give a crap about that are nurses, because we work with them every day. And you, okay. But I mean, I've seen, and I know, I see it every day at my job. I have a supervisor who was afraid to confront practitioners. I mean, and they are doing everything. And so the latest, like, you had asked me how my week was going. So her response to make things easier is to keep me out of the loop. Now, mind you, I created the queries. I created query templates. I created the program, the protocols, and everything. So now I don't even get included when she has, because they have these. She has these things. Let's discuss. I don't get the emails. I don't get anything because earlier in the week, we had a little kerfuffle, and and I told her, I said, you can change anything all you want, but until you have enforcement and accountability, nothing is going to work. So you can change all you want, but that's not going to ever address the root issue.
Well, look at their strategy on how they trying to.
Listen.
Bless their whole heart. And they don't even know who they're dealing with, do they?
No, they don't, because because between me, you, and whoever else is listening, guess what? I have a salary. I work officially 4 hours a day, and I'm good.
All right.
And I stretch it out to the rest of the day till I get ready to go lay down and take me a nap. And I'm good with it. Thank God for it.
Amen. Okay, and the other article I had, we talked about social determinants of health, and how important it is making sure that we track, as we've seen through the pandemic, we've kind of highlighted a lot of the inequities as it relates to healthcare, and the American Hospital Association, who is responsible for bringing you the coding clinic, has put together a beautiful document that talks about it provided some guidance on how to code for the social determinants of health, and the importance of coding for social determinants of health, and how you can advocate and advocate for the use of them. And really, any clinician can document a patient's social needs. There's a whole category, the category Z55 through Z65 actually is where the social determinant of health codes reside. Unfortunately, I think the problem comes in is with, it's all about reimbursement. And so folks have been told, well, if it's nothing to do with the reimbursement, why, quote unquote, waste my time in coding those? Why use those? And, at some point, and I know we as coders, we've been taught, or should have been taught the importance of the codes, that while here in the U.S., it's tied, and in other countries too, not all, but some other countries, it's tied to reimbursement. It's bigger than reimbursement. It's about the statistics. It's about the data gathering. It's about understanding, when you hear about the leading cause of death for XYZ disease, well, that's based on coded data. That's based on coded information. And that doesn't have anything to do with reimbursement. So you have to think bigger. And I know you got coding rules and you have guidances that help you sequence. And so there's a place for both. You make sure you do what you need to do to be reimbursed, but you still got extra lines that you can add, extra spaces to add additional codes if needed. And that's where, this comes into play with adding these social determinants of health codes. So I think this was a great document that kind of gives you information and understanding about these social determinants of health. I know I've done a couple of videos on this before, just really getting folks to understand the importance. Oftentimes people don't have the best outcomes because not for a lack of, going to the doctor or seeing the doctor, or in some cases having access, but there may be other external factors around their environment that keep them from being compliant with medication, or keep them from performing the appropriate treatment actions that are necessary. So those things need to be known and put into play. And while one provider may know it, all providers who are responsible for the care and treatment of a patient should. And one way to do that is communication through the patient's medical record. So I think this is great. Hopefully, there are a lot of other organizations who are also advocating for the use of AHIMA is one of them, use of, the social determinant of health codes. Hopefully, with the AHA, the AMA, I know they've had discussions and are talking about it too, and I believe they are also part of the group that are advocating for the use. So hopefully, folks get on the bandwagon and we see more of this as we move forward. Your thoughts on this particular article?
I agree with you in terms of the validity of the codes, but I'm just thinking in terms of productivity. When you work as a coder, you're in a productive environment. Like, they have quotas, and they are really, really strict about the quotas. And I know, like, when I worked in home health, like, it was nothing to have 25 to 30 ICD-10-CM codes, like, that were related to their conditions. And then to have to take out the time to put in 3 or more additional codes, because also, even when you go to submission, all codes get submitted, but they want to make sure that the ones that pay are in the top, at least like top 12.
Correct.
So there's a lot of, there's a lot of play. And if it comes at the, anything that comes at the end is the first thing to get cut off when you're in a productive environment. And that's where those social determinants of health codes would go. And I just don't know, unless they ease up, not change, but ease up on the productivity environment, I don't see how you'll be able to effectively capture it, although it needs to be captured because, like you said, it is really important data, and they could really do a lot more in terms of social policy if they had more data. So it's like a catch-22.
I agree. And yeah, it's unfortunate about the productivity caps and rates that they have out there, depending on the setting in which you're coding. But again, to me, I think the outcome, the positive health impact and outcome of the patient supersedes that. Again, that's probably a conversation within the HIM or AHIMA. Let's talk about, this additional information. Is there a way that it could be easily accessible or readily provided that it can then be captured quicker for those who are abstracting and pulling and coding the information? But I think, just my humble little opinion, that that productivity shouldn't be the reason why they don't capture it. And again, I think that's just a bigger, broader conversation for some of these organizations. And as they begin to push that, maybe that's something that they need to bring to the table.
Okay, we'll see.
It's all relative at this point, but hopefully, it's something that moves the needle. Did you want to talk about the news thing that I missed last week? The Centers for COVID Control and the Doctors Clinical Lab?
I just think that we're just gearing up to go into overdrive with these audits. Like, it just is what it is. They're slowly ramping up, and I just hope that people are prepared.
I hope they're prepared. We'll
really
be preparing them soon.
Yeah.
If you need some compliance assistance or help, get with us. We may have something for you. So we're talking about, there was it NBC News? National News?
Yeah, MSNBC.
where they were talking about probes on these pop-up testing centers, and one was the Centers for COVID Control and their lab, the doctor's clinical laboratories. And I was sharing with Jesse, the doctor's clinical laboratory has some challenges before, so they're not new to this rodeo. So you would think they would make sure all I's are dotted and T's are crossed. But they have been billing for, they built government services, Medicare, Medicaid, for at least $122 million just on these tests, the COVID testing, and at these pop-up clinics. And the things that they were uncovering was the information was not correct. The patient's names were not on the lab tests. The results were not provided timely. Some of them didn't even get resulted and were just a waste because you couldn't use it after so long, but they still billed for it. It was a mess. And then, of course, they showed like the CEO who had just built this mega mansion somewhere. But at the time of the broadcast, they actually had halted their operation and were doing some deeper dives, or I guess probably trying to figure out what in the world is going on and do some damage control as it relates to what the Department of Justice was, or the feds were uncovering. And then the funny thing about that was I received an email, an article about something, and in it was like the OIG is hiring. I shared that with Mr. Jesse. I said, oh yeah, it's on and popping. The OIG done put an ad out. They are hiring. They're looking for folks to help them with this massive overhaul, because I'm sure not only do we see it, but they see it. They probably saw it before we did. So this is crazy. And then over the weekend, I was helping Neva with her question, and I did a deeper dive into.
Okay, good. I'm glad you brought that up, because I think I figured it out too. But go ahead.
Well, part of it is like your NCDs, LCDs. That's applied specifically for your traditional Medicare, Medicaid. HRSA has a whole different set of rules and regs that you actually have to follow. And I think you mentioned it last week, and I think you've mentioned it before, and it's clear. There's a whole terms and conditions document that they are certifying to with several points. And one of those points was clear that when you submit that claim, it has to be complete. There is no going back. There's no, you can't resubmit. You can't do the corrections that you could do on a traditional claim according to their rules in that document. So yeah, and adjustments and all of that don't necessarily exist in the HRSA world where it does with traditional Medicare and Medicaid, at least, again, according to that document. And then there was something else that I found interesting. So there is a report that is supposed to be sent every quarter by the providers. If I believe the threshold was $150,000 if they're receiving funds of $150,000 or more. So every quarter there is a report that must be sent, I think, within 10 days of that. And I think that in and of itself could be, if you're not doing that, could be a condition of not following or adhering to the terms and conditions of HRSA, which can then delay or decrease your reimbursement. So it was a lot of stuff in that terms and conditions that hopefully folks have read and understand what they're certifying to. And then like the labs, there was a whole section about the labs and how they differ from the physician office or the hospitals, and what in particular labs need to do to make sure that their claims are correct and they're using the appropriate codes. But what did you find?
What I thought about was, because NIVA has said that it was denied for medical necessity. And then when I thought about it, because it's a combo COVID and influenza test.
Mm-hmm.
So in terms of, so that means you have to have a code for a screening for COVID and screening for influenza.
Correct.
But according to HRSA, they only authorize COVID testing. So if they only authorize COVID testing, then they would not pay. It doesn't seem like they would pay for a combination test that would test for COVID and influenza at the same time, because they don't pay for influenza testing.
But that code is listed in their list of codes that they do reimburse.
But they're all, but they should include a code.
Have to make sure you sequence it appropriately. I mean, as far as having, because they're real clear about the COVID diagnosis being your principal diagnosis. They're real clear about that.
But there's no other acceptable codes that are on the list that will cover influenza. They don't have the list only covers COVID. Like, it doesn't say, like, if you're going to use this code, you can use screening for influenza Z something else. It doesn't. Mm-hmm. They don't supply that.
So I'm wondering if that's a code. I don't even look. I'm looking. Is she on here? If that's a code, do they add that as an additional code? The screening for influenza, making the COVID code first, and then have the screening for influenza as a secondary code. I don't know.
But that should come from them, though.
You're right. That should be guidance directly from them to help them. Because, particularly now in this season, this flu season, and they were, at least in our area, they were promoting get both your COVID. It's okay to get your COVID and your flu shots at the same time, and they do list that code as a code that is reimbursable from that program. So, yeah, right. I think they need to.
Right. But when it says medical necessity, that definitely says to me that there's a problem with the ICD-10-CM code, not the CPT. So I think that's the missing piece. You have to have, and maybe it could just come down to have the COVID testing Z code first, and then find the code for screening for or encounter for influenza testing as a secondary code, and then have the diagnosis pointer have both of those codes in that diagnosis pointer column.
Well, they do have a comment section. Maybe we can ask. Somebody can ask. Reach out to HRSA. Have those conversations and ask.
It's a lot that goes into, like, people think that billing and coding is, people just have a misconception of the HIM profession, period. And people think it's just looking up a code or a procedure code and putting it down on a piece of paper. It is so much more than that.
It's so much more than that. And, even, like I mentioned, being curious and asking the questions, like, well, why? Why this, not that? Or, why that, not this? And or understanding the why behind why you do some of the things that you do in coding. I mean, one of the greatest gifts we've been provided is our little Bible, which are the guidelines. Guidelines will give you a lot, but then those guidelines come from regulations. Those guidelines come from public policy. Those guidelines come from even the medical profession and protocols and such. So there's a whole bigger, I want to say monster, but a whole bigger picture that's happening in conjunction with the end result that we get, which are actually the coding guidances and guidelines. So, yeah. So was there something that you actually had, that you ran into this week that you wanted to share with the folks?
Not really, because I was kind of,
You was busy.
Yes. Because my, this week we covered sepsis in my coding class, and sepsis is a lot, especially when it comes to documentation of an acute organ dysfunction. And I've just been trying to, and what seemed to really work. And I'm like, wow, like I have to remember I wrote it down. So I told them, whenever you see acute respiratory failure documented, you always want to look for an additional term like hypoxia. And I said, you want to scour that document like you're looking for your missing child at a park. And they seem to like that one because they remember it. So that means it is working. So and that's something that and all mothers can relate to. So you have to look because it does change how it gets coded. And doctors will never document the way coders want them to. They will never lay it out in their assessments 1, 2, 3, and never tie it all in. You have to piece together a story. And that's what I tell them coding is. You have to read through this and put it in alphanumeric code that makes sense, that accurately depicts what's happening in that scenario at that time.
I agree. I was going through I had noticed, realized, and probably because of, did you get your email from the AAPC about the exam?
I probably did, but I probably haven't.
Didn't pay attention to it. So I think there's some buzz because the email kind of was trying to answer questions related to, are they asking enough questions, or is there enough content now on the exam that qualifies a person that, I guess, that passes the exam as a quote unquote expert in that area or expert in that field. It was a tone to that email, and I was just like, I was chuckling, like, really. And of course they went back to their focus groups and in the white paper and such. But I was like, okay, so I guess there was enough buzz that they felt compelled to send this in an email to folks. So I thought that was quite interesting. But then I was actually going through and looking at the final rules. So I'll be doing some videos in the next couple of weeks on not only the ops final rule, but the physician fee schedule final rule. And the one thing that jumped out at me that I talked about this week was the civil monetary penalties and how they have increased. And I think, because there has been a lot of talk about and a big push with the hospitals and the pricing transparency, and the government they're not budging. They're sticking their feet in the sand with what the expectations are as it relates to that. And so I know, the hospital associations and hospitals, and they're all arguing, there's a burden in making sure that we do this and have this and all of those things. But the government is still like, okay, and yeah, thank you for that information, but this is what we're looking for. This is the rule, and this is what's happening. And so they have increased the amounts. Now, if you're a smaller hospital, you don't, of course, pay as much as a larger hospital, but they, like the non-compliance for a year for a larger hospital looks like $2,007,500 per hospital. So imagine if you are a hospital system with multiple hospitals that are non-compliant with the public access to pricing information. And it is deemed that you now have to pay. Can you I was floored. And you see, I can't even get it out. Like, right. Y'all about to run out of business. Y'all about to be put out of business. They're not playing with that. So don't play with them.
Well, I don't think they'll be put out of business, but it's just they're about to see their profit margin slash because
if you're not seeing patients, you don't have with everything going on today. You got staffing issues, COVID, reduction in services. I mean, you got a lot of stuff going on.
Right, but the real issue that's going to come from that is not really for the uninsured. It's going to be for the insured people, because what's going to happen is people who have Cigna are going to see that people who have United Healthcare have a better plan than they do for the same hospital, and they pay less for services. That's where the kickback is going to come in, because then they're going to have less, because it's going to be exposed. Okay, well, if they're only paying this amount of money per day for inpatient, why am I paying this amount? Mm-hmm. So that's why they're upset, because they're going to have their bonuses slashed. But it's long overdue. I mean, like a lot of people, I've had this position for years, and you've been in HIM way longer than me, Clarice. And what people don't understand is doctors are the reason why we have all of this. They have been they have been stealing, and it's no other word for it, stealing. They have been stealing billions of dollars for years from insurance, Medicare, and Medicaid, and all of these are stopgaps to try to avoid it.
Yeah. So it's gonna be interesting. Oh, and then there was a new. I'll talk about that too. They slid in two PCS codes related to COVID as well. They had the 7, now they've added 2 more for the April 2022 release. So I'll talk about that in a future video as well.
I love PCS.
I know you do.
Truth be told, I can't wait for them to make CPT like PCS. It will make it a whole lot easier.
Yeah. And like you said, it's really understanding those operations, understanding that there's a flow to it.
Once you get those root operations, it is like taking candy from a baby.
It's like candy from.
Yeah, it is. You can't go wrong. Okay, so anyone have any questions, concerns, issues, feel free to come on up to the stage. Join in the conversation. Don't be shy. There are a lot of folks in the clubhouse. Yeah.
You all are not virgins to the mic, so feel free.
We covered a lot of territory, so I know people have questions.
And you can just raise your hand. I'll invite you to come on up to the stage.
Hi, good morning.
Good morning.
My name is Dagwa. You say it correct way.
Yay! I'm so glad because I hate to butcher people's names.
Actually, I'm going to change all my career path. I graduated from law.
Okay.
And I just enrolled in AAPC.
Okay.
Medical coding. I'm 0. I'm like pre-KG.
Okay.
Yeah, and I like what you're talking about it. Actually, I'm from Sudan. My mother language is Arabic because it's
okay.
From my language.
Okay.
Just only I'm very scared about this career. I hear a lot of information. Yes, some of I hear about it. Some of it very new for me. But what is the good tip you can give it to me when I start this career? What I have to focus in on it, and how can I success in medical coding?
Well, first thing is welcome to the club. Welcome to the career and the profession. But you come with a law background, and so you know the importance of regulation. You know the importance of guidance and guidelines. And the same thing applies to your coding profession. So understanding the why behind, as I mentioned before, the why behind what you do, and understanding those rules and regulations and guidelines will help you succeed in your coding profession. Mr. Jesse, did you want to add anything to that?
I just want to echo the same point. It is really all about knowing the guidelines, the regulations, and the code of ethics.
Okay, that means I get a 15. I'm scared until the death. I swear to God, I'm scared. But my friend, she pushed me. She said, "Okay, we're gonna start together. We're gonna help each other." I said, "Okay, that's fine." I read a lot. I open YouTube because I'm gonna start my first class next February 9th.
Okay.
Yeah, and I want to search here and there, and I see in the house club this room, and immediately I signed to any coming up.
Oh, well, yes, definitely. We provide the information. I have a student in my class now that she's not in my class. She's part of my coaching program that I launched this year. And she's taking the AAPC classes as well. And so because there isn't a instructor per se, it's self-directed. We kind of touch base and I help fill the gaps for, helping her, because it's a lot of information in that program. And you can get overwhelmed, and she was overwhelmed. And I was like, ma'am, let's focus. These are things that are important. These are things that you need to know, and helping you focus. And so she's working me. I will say that. Because, I don't want her to feel like, so for example, I'll give one example. We were talking about anesthesia, and and I gave her like, these are the takeaways that you need to have from anesthesia. And she was like, well, what about this? They're talking about, the how you come up with the anesthesia payment, the base, the time, and the modifier. And I was like, yeah, that's great information to know. You can know those basics, but unless you are coding for anesthesia for the anesthesiologist, and most people don't, that's way more. That's more information than you actually need. And so it's like, don't focus on that, because she wanted to figure out the formula and how to plug the stuff. Ma'am, no, that's not where you need to focus.
That's true, because when I opened the YouTube, oh my God, they pull a lot of information, how they do coding, how they transfer all this information from the report, doctor report to the coding, and oh my God, I feel like I'm dizzy.
Yeah, so I mean, really, again, align it with the guidance and the guidelines, and that'll help focus, because it's good information. Don't get me wrong, it's good information, but as my friend Jesse always says, sometimes it's a lot of fluff, and you got to weed through that fluff to get to what you need, especially to be successful with the certification examination. So.
Do you think if I work like a training during when I'm start my medical coding class in a hospital, is gonna help me, or I'm gonna confuse myself?
Well, you definitely need the certification, but once you get into a facility, they'll have their kind of culture in which they do things, and so you will learn what's their way, and hopefully they have some sort of documentation manual. Now, it should be aligned with the official coding rules and guidance as well.
Should be.
But, depending on what specialty it is. So, but you're getting a broad overview with the AAPC in all of the different areas. So say you specialized and you go into cardiology, and you are working at a cardiology hospital, then you're going to go deeper than what the average person would know as it relates to cardiology. And so they would help bring you along and provide you the additional training and education you need for that particular specialty. So again, you're getting the base information enough to show the world that you've mastered, the basics and the guidelines and the understanding of, coding and what it entails. But then as you go to the various areas or facilities in which you're working, then they'll help you along. A good facility will help you along and have the training and maybe even mentoring someone there to help, walk you through that particular specialty if you're in a specialty, or even just general. I mean, there are some things even in a general, if you're coding all kinds of stuff that you'll run into.
Mm-hmm. Thank you very much.
You're welcome. You're welcome.
You'll see me in the future.
Well, stay connected. There's plenty of folks in the room that are great resources. So feel free to, connect and follow folks. And yeah, definitely. And if you have any questions, any other specific questions, don't hesitate to reach out. You can.
Of course. Thank you very much.
You're welcome. You too. Hey, Dale.
How are you this morning? Hi, everybody.
I'm well. How are you?
I'm pretty good, thank you.
How's it going?
You have a question. I've been at my former employer for 14 years, but I was terminated because of the mandate. And the place I was working at was like the hospital I was working at was like a education facility, and they provided I guess the resources for ICUs. So I was wondering, being outside of that, how can I go and get some ECUs? I mean CEUs. Sorry.
CEUs. Okay. I'm like, I see you. Wait. Yeah, I'm trying to understand. Okay, no problem. So what do they need from you?
I'm trying to get CEUs for my keep my credential.
Okay. And which credentials do you have?
CCS.
Okay. Let's see. Short of, I know there's usually webinars, some free things. They still allow for the CEUs if you go through, I don't have it in front of me, AHIMA's journal, and you can provide, I think they usually have a quiz or a test or something that you can provide information on that. I think you can get some free CEUs that way. I would reach out to your state association and see if there are opportunities for CEUs that way. I'm trying to think, what other, Jesse, you know any AHIMA's sort of?
What I do for AHIMA is I have never taken, the only AHIMA CEUs I ever got was when I did their approved trainer program for ICD-10C and PCS. But other than that, like I've only used, because AHIMA accepts AAPC CEUs, so I just get my AAPC CEUs and then I use them for both AAPC and AHIMA. So I just
and I do the same. I actually use my when I go to larger conferences, it usually covers, and my conference of choice is the compliance conference. But yeah, look, usually there's different organizations that have, there's a publication, I think it's called For the Record, and they usually have articles and information on different things you can do for CEUs. Yeah, just having the one, so but you can, like Jesse said, look into other areas like AAPC, any compliance, and just make sure that they allow for AAPC or AHIMA's, you get permission to use them for AHIMA as well.
Okay.
But I was trying to think of some free things, and I know like the article things are free. What was I on? There was something just this week that provided some free CEUs. I think it was a compliance thing that provides some free CEUs. So just look around, see what's happening with AHIMA and or your local state organization, and see what they have going on, and see what you can plug in to get those.
Thank you so much.
But make sure that you verify and validate that CEU will fit the domains for your AHIMA credentials. So you got to be careful with that, because you got a ticking time.
All right, thank you.
You're welcome. Hey, Faith, how are you?
Good morning. I'm fine. Excuse me, I'm in the car. I thought I'd be home by the time you got to me. But I did have a question in regards to, as I'll be graduating in March with my associates in HIT.
Mm-hmm.
But I was wondering, as far as, sitting for my exam, does it matter whether to do it through AHIMA or AAPC? Is it more so focused on if I choose to, do inpatient, outpatient? What's your recommendations on that? And then also, is it, as far as my credentials go, should I focus, because I do want to eventually, go for my BS and HIM. Should I even consider going after my RHIA, or focus more so on the, CCS and, go that route?
Okay, so before I answer your question, Sharon sent some information about the BC magazine. Has opportunities, is B as in boy, C as in color. Magazine has opportunities for CU as well. So I wanted to share that love. You're welcome.
Okay, thank you.
You're welcome. Okay, so Faye, let me see. So what's the end goal? So you said you want to get your BS in HIM, but are you kind of using the coding as a stepping stone? Is there something in specific in the profession that you are aspiring to do or reach, or?
Right, I am. That's exactly. So, as far as the coding, as you said, like just a stepping stone, of course, to get my feet wet, to have that understanding. And then, as I elevate, because the end all, I would like to open up my own practice, and that's a little later on if I go back for a master's, where I'm able to train and, have my own little practice of, if that's the term, of coders, underneath me, because what I've noticed, there's a lot of outsourcing going on as well. So, I wanted to possibly, look into that as well if I had my own business, if that makes sense.
Yeah, that makes sense. Mr. Jesse, did you want to?
I'm not even really sure what's going on, to be quite honest, because Faith got a lot going on. So I don't know. So I'm not sure whether the credential she's talking about is an RHIT. Is it? Are you trying to get a CCS? Or are you trying to get a CCS, a CPC? Like, what exactly are you? What credential are you talking about right now?
Well, I think she's in school right now,
right,
for her HIT, and that's where she's graduating from. Correct.
Right.
That's correct.
Okay.
Okay. Right, but you don't. But you, when you finish with your associate, you can sit for a CCS or you can sit for RHIT or CPC. So I'm just trying to figure out which one is she talking about.
Well, I think I would recommend, depending on your program, if you're going into a coding credential, I think you would need to kind of hone in more on the coding aspect. Your general associate program gives you information across all of the HI disciplines, and so you have a couple of coding courses, but maybe not as much that'll drill down for a certification. At least that was my experience.
No, you're right. And I guess that's where I'm kind of, like you said, all over the place. I'm not for sure, because I do want to, hone in more on the coding, but then I'm like, okay, how do I go about it? And that's why I asked about the HEMA or AAPC,
So AAPC is, originally it was geared for professional coding, so for providers, for physicians and the like. But they've expanded and broadened their certifications to include hospital outpatient as well as hospital inpatient. So I think at some point you need to decide which way you want to go, because the flow or the credential that you ultimately sit for and apply for is determined based on that whether it's inpatient, whether it's outpatient, whether it's professional. And then that can kind of help you narrow down, what your focus would be. Or, if you want to hit them all, which is, there's several folks with the alphabet soup behind their name who's actually hit them all. But at whatever point you decide to sit for the certification, you would need to focus on that area. So say you finish in March, you want to get your inpatient certification, you want to get your CCS, then you would need to make sure that you're focusing in on everything related to inpatient hospital. So you want to make sure you drill down to all of your IC10. You want to make sure that you're drilling down with your IC 10 PCS, you want to make sure you're drilling down on all the guidance and guidelines related to that so you can be successful for that exam. If you're sitting for the AAPC and you're looking at the CPC, then CPT is your focus of choice. And so you want to make sure that you are well versed in the guidance and guidelines as it relates to CPT, because the overwhelming majority of that exam is about CPT. CCSP, you're kind of on the fence, but it's provider based as well. But there are some CPT questions. They need to change the names of these things. CPT questions, and so you need to have that focus as well. But then also understand you don't have to incorporate ICD-10 PCS. So again, it just depends on where you want to focus initially as it relates to the next step once you graduate in March. If that makes sense.
No, it does. And I guess the biggest thing, because essentially I want to build up. I want to be, most marketable, most valid. So I just didn't know, which way to take, since it'll be the HIT, as far as educational wise, but then which certifications to go afterwards.
And this is just a side, and you can take it for what it is. I mean, if your end result is to open up your own practice and have the coders under you provide the outsourcing, I mean, at the end of the day, technically, you don't need none of them. You need to make sure your coders have them, and you market your coders appropriately. But that's a whole other conversation. Yes, you need familiarity and need to know enough or have the appropriate people on your team and in your staff to assist and do quality checks of the coders that you have, et cetera, et cetera. But your team and the credentials and services that your team provides is what you would sell as outsourcing for your business. But again, that's a whole other conversation.
But what I would like to say overall, the only thing I want to leave with you, Faith, is if you are trying to get into HIM, you have to know how to code. Period, point blank. And it doesn't matter which credential you get, because you still have to, every job you get, you're going to take a coding test. It doesn't matter. And if you don't pass that coding assessment, you're not going to get the job, period. It doesn't matter what credentials you have. You have to know how to code, and you have to know how to use a coding book. And what I have found in my time tutoring, and even since, I used to tutor for an HIM program here in Philadelphia, and even with me tutoring people, aside from the people who I teach in my own class, people do not know how to use a coding book. And it doesn't matter what credential you have. If you don't know what a non-essential modifier is, if you don't know how to index properly to find a code, if you don't know how to go into the tabular and verify the code and read the instructional notes, go to the top of the code category to read any additional documentation, it doesn't matter what credentials you have, you're never going to work. You have to have a knowledge base, period. Credentials mean nothing without the skill to go behind it.
That's very good. No, and you guys both have answered my question. I do. I want to throw out a little curveball because I'm looking at the profile, Ms. Jessie, and I just, again, because I'm kind of all over the place. The reason I even got into the coding side of it, essentially, yes, I did want to go out to nursing, but the NCLEX, that math portion, I do struggle. Do you tutor for that?
So wait a minute. Stop. You are almost a nurse?
Yeah.
Wait a minute. Faith, you are, let me tell you, anything you want to do in HIM, if you get your RN, you can do that times 10. You got to get both.
Like I said, it's that I can't the math. I just can't.
All right. Listen. Just private message me. I know some people who can help you. Let me tell you, can I just share this story with you, with everybody? I had a young woman reach out to me from Alabama. I don't know this woman from Adam. She got her CCA. She went into coding because she could not pass her RN exam. She failed it 5 or 6 times. And she was like, I'm just going to go into HIT. I said, you're going to do no such thing. I said, what you're going to do, you're going to pass that RN exam first, then you're going to go into HIT. I said, you have no idea how much it can set you up. So I found some people who I can refer to you as well, Faith, that this is what they do. They help people pass the NCLEX. The day before Thanksgiving, she passed her NCLEX. The next week, she was interviewing for a clinical documentation improvement position at her local hospital because she was an RN. I'm telling you, Faith, that's the way to go.
Which I will be fighting, but that's a whole other conversation.
But I'm telling you, but that I don't make the rules. I just try to tell you how to finesse them to get what you need.
You know, I'm an advocate for my profession all day.
I get it.
Oh, but thank you, Faith. Any other folks have questions or just want to stop by and say hi? Thank you, Sharon, again for the information for Gerald. That was great. Good morning.
Can y'all hear me?
I can hear you now.
Hey, I was just chiming in. Just woke up, getting ready for work. I worked 12 hours, and he kind of got me saying something about getting the RN and then getting into HIT. I've been a nurse for 16 years, but I've been kind of looking into the code here and there since I got into this CLIA wave lab thing. But he kind of just opened my eyes about going into that direction once I get my RN. So Faith, she kind of, I just woke up with good stuff. So I just wanted to say good morning, and I'm done speaking.
Well, thank you. And hi, Felicia from Atlanta, Georgia. She's checking in on our YouTube channel. Welcome. Okay, Mr. Jesse.
Listen,
what's going on?
This is why I created the Coding Nurse for people like Faith and people like Mary, to bridge the gap, because you can do both, and you need someone like me, and you need someone like Clarice, because Clarice is a subject matter expert in HIM, and it's not about credentials. It is about experience and time in the game. You have to know credentials don't make you an expert. Credentials just help you meet some minimum requirements for a job. After that, you have to have skill, you have to have knowledge to produce and to be productive. And Clarice is a subject matter expert when it comes to HIM. I tip my hat. I am a co-host. I'm not the creator. I bow down because I know greatness when I see it. And that's why I'm here every Saturday, because Clarice knows her stuff. I just have a different take on it because I came into HIM from a clinical background, being an LPN. So that's why I can speak directly to nurses who are trying to transition. But once you transition into HIM as a nurse, you're going to have to listen to Clarice because she knows what she's talking about.
Well, thank you. I appreciate that. And I love that I have a clinician that I can bounce things off of as well. So it works great.
Exactly.
This has been good. Let's see. Any other questions?
It's good every week. We really give out some good information here, Clarice.
I think we do. That's part of, my overall goal is to be a resource and provide some valuable information. And even, sometimes I had a friend who would tell me, sometimes your stuff is just so technical. And I was like, yeah, I know, because I know my audiences. I have very varying audiences. Certain things don't necessarily apply. But I feel like our things today, or our Saturday morning tea, allows us a broader audience where we can break things down to people who are either in the field, in various fields, because Lord knows I'm learning all about HRSA and these CLIA Labs just on these Saturday morning calls.
Yes.
What in the whole world? Do I need to go start a CLIA Lab? Let me find some nurses. But But this is a way where we can broaden the knowledge base and the information. So whatever area that you're in, feel free to share the information. Like I said, I learned something new every Saturday. I mean, I'm walking away like I keep y'all don't see this. I keep a whole notebook while we talking. I'm like, wait a minute, hold up. That's why I can't. I'm struggling with making sure I'm doing my producer role as well, because I hear things and I'm like, okay, that's something. That's something. And oftentimes it's something that somebody else needs to know or needs information about. So I use it for topical information where let me do a little more research. I mean, because oftentimes my questions are on the fly and I'm like, okay, it's early in the morning here for me too. I do have my tea, but it's still early in the morning. But I want to make sure that I'm providing you the latest and greatest information. So, oftentimes I'll go back, and even after we've discussed and closed down for the day, I'll go back and say, or, throughout the course of the week and say, oh, I remember so-and-so asked about blah, blah, blah. Let me see if I can find some more detailed information to assist and help. And I think part of that is the compliance officer in me as well. So, and the educator. I'm trying to make sure you are armed with the information and knowledge you need to make the best choices and decisions for you. And I'm so blessed that I was able to partner with Mr. Jesse, again, because of his clinical background. He has more understanding as it relates to, that clinical piece and how to marry it and how to transition, because he's actually transitioned in that area. And so with his clinical knowledge base, with his understanding of what's important as it relates to the coding profession, coupled with, his dibbling and dabbling in all kinds of other areas, it makes him a well-rounded marketable professional as well. So I'm just glad that we are able to provide this, and I'm glad that you all take a few moments out of your Saturday morning to join us and listen to some of the things that we have that are here to help, and hopefully find a friend. If you're in school or you're going through school, then hopefully there are opportunities where you can connect and reach out and help each other along. Or we're here as resources as well to help. And then on that whole other side, if you are already in business and you're up and running, but you have some questions and we want to make sure that your business isn't targeted and you won't show up on somebody's list, meaning OIG Department of Justice list, then we're here to help in those aspects as well. So again, just and it's just us, our reach is only so big. So we rely on you to join us and share the information and let folks know, hey, we're here and, we'll help as how we see fit. Hi, Kathy. I'm new to Clubhouse. Oh, I'm sorry. I didn't know if you want to come up. She just gave me a message. Kathy, I'm new to Clubhouse. Welcome. I've been a coder for 8 years. I also have an AAS in HIT. But right now, after listening today, I am really thinking about the whole getting a nursing degree. So you moving people over to nursing. I'm going to need you to stay with me. No kidding.
I totally agree. Kathy, stay where you are. See, everything is not for everybody. Like that was for Faith because Faith was already in a nursing program. She just needs a little fine tuning to help her get over the hurdle. You don't have to go to nursing school to have a successful career in HIM. Clarice is a prime example. Exactly. So if you have that skill, you can kind of parlay it to kind of help you, make entrance into a new career. But it's not a requirement. It's just that if you so happen to find yourself in that situation, you can make it work for you. But for you, I would just tell you, I would give you the same information, same suggestion I gave Faith. Learn how to code, learn the guidelines. That's what's going to make you a success. Being a good coder, knowing how to interpret the guidelines, knowing how to sequence, knowing what is required of you and your skill.
Mm-hmm. That's it. You mentioned something about like the essential modifiers and all of that. And I was having a conversation with someone the other day, and she was like, "So, am I supposed to use my index every time?" I was like, "Ma'am, don't make me come find you. Don't make me come find you, please." I was like, absolutely. And so she was my coaching person, and she was like, "They don't tell us that. They don't tell us that." And I'm like, oh, God.
Because case in point, at my job, they have openings for coders, and they only take people who are, you can only get a job if you're certified, not necessarily experienced, but certified. These people have experience and they're certified, but none of them have been able to number one, pass the coding assessment. And if they pass the coding assessment, they can't pass the interview, because when they ask them to index certain conditions, they don't even know how to index. Like, that is a must as a coder. A must.
A must. A must. Bless their hearts. Lord, we see we got a lot of work to do.
Yep.
In educating the masses. And again, you know, regardless of where you've gotten your coding training, there are just some basic things that are required. And hopefully, you know, you keep plugging in, you keep checking in, we'll get you to where you need. And then, you know, I know Jesse has his classes. I have my classes that, you know, if you want to help you get into what's necessary and what's needed and to pass that certification exam. Primarily, I focus on the CPC, but you can also take the same information, because one reason, because someone asked me, like, well, you don't have the approved instructor for either, and that's intentional, because I teach to both. So I provide the information for both. So whichever way you want to go, you can go. Years ago, when I was teaching for a particular organization, and they had, I believe we had the AAPC, we're using AAPC program at the time, and they were like, you know, this is proprietary and you can't do anything with the HEMA, you know, and I was like, oh, this is foolishness. And so from then on, I was intentional about making sure that I provide the information that carries over to either way you want to go. So I'm intentional about that.
Yeah. Coding is coding.
I'm sorry?
Coding is coding.
Coding is coding. Coding is coding. So yeah. Cool. So feel free to reach out and get in touch with us for any specific needs that you may have. Well, this was a good Saturday morning.
Yes.
Again, thank you all for joining us. You know, my favorite question, was the tea spilled today? Was the tea spilled today?
I believe so, yes.
Yes. I see you guys flashing in Clubhouse. Yes. Again, if this information was valuable for you, help us share this message with others by liking the videos or sharing the videos and subscribing to our channel. You can also check out the Coding Nurse channel on YouTube. He's looking for subscribers as well, and hit those notification bells so you'll know when we upload new videos or when we go live. Of course, last but not least, to my Clubhouse folks who are near and dear to me, this is how we started even this whole YouTube channel, was through the Clubhouse people. So you guys are always near and dear to my heart. Make sure you click on the green house to join in our fun, in our club. And you will also get notified when we have our live broadcast. We are generally here on Saturday mornings. Hey, Tasha, how are you? She's in the thumbs up. We're here on Saturday mornings at 9 a.m. Eastern Standard Time. Even though if you can't make the live session, that's fine. I usually take the time to edit and go through the live session and repost it on YouTube. So it's also there on YouTube for you to go back. And say you missed something or popped in late, you can always go back and look at the rebroadcast. So again, this has been a great session today. Thank you all for joining. And remember, be safe, be kind, and don't wish for it. Oh, wait. before I go through all of that, Mr. Jesse, did you have any closing remarks?
I had no closing remarks. I mean, as the Jan Levan says, I am complete. This was a great week.
All right, look at you. Quoting my girl.
Yeah.
I love it. All right. Well, again, my boys are still in it. We play tomorrow. Come on, Cincinnati Bengals. Come on, y'all.
I meant to tease you last week when you were talking about it. I'm like, Cincinnati hasn't had anything to celebrate since the Icky Shuffle.
Years. Do you hear me? So we're excited here. I actually did my mom goes to a senior center, and we had a tailgate yesterday. They bore me out. They had a tailgate, and we actually had some Bengals, some older Bengals come in, and mingle with them. It was really, really nice. We had a great time. So everybody's spirits are high. We're all, hoo day. I'm like, okay, all right, while y'all hoo day, and please make sure you keep your mask on. Please make sure you're social distancing. I don't want somebody to be hoo dayed up, and then we'll be at your funeral in 3 weeks. So be mindful of all of that.
Right.
As you gather. Keep those protocols. The pandemic hasn't gone away just yet, even though we're ready. Because the Lord knows the ocean is calling my name. I need to see her soon. But anyway, this has been great. Thank you all for joining. And remember to be safe, be kind, and don't wish for it, work for it. And until next time, take care. Talk to you soon.
All right. Bye-bye, everybody.
Bye-bye.